This is video 10 and a review of everything discussed throughout the video series, and it's intended to be an overview of use with your Medmont E300 Corneal Topographer. If you click on the patient name and the clinical tab, you can enter in the patient's spectacle RX if designing a rigid lens from your Medmont software. With the home icon selected, you can capture topography, create new patients, delete patients. You can link specific maps to third-party softwares. With the configure option, you can create specific records to relate your Medmont to both the practice, to patients, creating new fields specific to the patient. You can calibrate your instrument with this function. These functions are used very infrequently, generally set up in the beginning, and the only one you're going to refer to on a more routine basis might be the calibration, which should be done every 6 months, or if you move your Medmont. If we click on a map, we have a number of functions available here. The first allows us to change the patient. If this map were saved to the wrong patient file, we can change it here. If this is not a left eye but rather a right eye, if it was incorrectly captured, we can change it on this window. The main function is your image button, and this allows us to view from 1 to 4 different maps simultaneously, and it's used most frequently. The second function is third function is your comparison map, and this allows you to compare 2 instances in time, a pre-Ortho-K and post-Ortho-K, or a patient last year's visit and this year's visit to see if there's any change in disease progression. The next function is your combination, which allows you to view the map a number of different ways. This function may be most valuable in looking at the photokeratoscope image, looking for the quality of the placido reflection, eyelash shadows, measuring visible iris diameter, pupil size, these type of options. Let's click back on the main image option and review some of the other analysis options available to us. If you click on analysis, this allows us to look at the details of this particular exam or multiple exams. We can change the axis that it's analyzed on. Generally it defaults to the flat meridian. We can change or set the chord of measure, meaning what diameter do we want to measure our information to. We can look at the flat meridian or the steep meridian. This is helpful when looking at sagittal depth, for instance. We measure the sagittal depth of this eye is 1453 on the flat, 1576 on the steep, approximately 123 microns difference exists between the flat meridian and the steep meridian. This tells us that this patient may require a specialty lens because there's greater than 50 microns difference between the flat and steep meridian. We could look at the E squared values, E squared being in negative, indicating an oblate shape. So across the flat meridian, this pellucid marginal degeneration eye has an oblate shape across the vertical or the flat meridian. On the steep meridian or the horizontal, the cornea is a positive E squared value or prolate. Oblate being flattest in the center, steepest toward the periphery. Prolate being steepest in the center, flattest toward the periphery. Let's close this window down, and we can look at the display option. Presently we have axial powered displayed. Axial is the best way to interpret the type of astigmatism, be it against the rule or with the rule. In this case we can see clearly an against the rule corneal astigmatism. Is it regular or irregular? An axial map helps us to understand that. And although there's a defined steep and a defined flat meridian, this pupillary zone looks slightly asymmetrical on this pellucid marginal degeneration patient. If we were curious where the steepest point of curvature is, we could select our tangential map and see that the point of most radical steepening is inferior. The point of most radical curvature change toward the flatter side is this deep blue area. If we were curious about which is the highest or lowest point on the eye, we could select our elevation map. Elevation map drops a perfect sphere on top of the topography and looks at whether the cornea is above the sphere or below the sphere. With the white axis line running vertically, we can see the dotted section of the line corresponding here with the dotted section of the line on the graph. And the elevation of this eye goes beyond the graph. In other words, the corneal elevation here is much higher than the spherical surface. This is a high point on the cornea. This point here is also a high point on the cornea in relationship to the spherical surface. However, horizontally, we can see by these blue areas we have a low point in corneal elevation. If we were to drop a rigid lens on this eye, it would lift at 3 and 9 o'clock. It would bear at 12 and 6 o'clock. Also on display, we can change any way we analyze these eyes. We could reduce the color map opacity to see more ring reflection, or increase the color map opacity to eliminate it. We could eliminate the image so just the colorized topography exists. We can get rid of the annotations, the cross-section, the attributes. So you can change the way your maps appear using the display and changing these options anywhere on this on the screen. You could click on perspective and change to a three-dimensional view, and if you right-click, select the pen tool, you can observe the corneal curvature in 3D along the entire surface area. This is helpful for patients in appreciating distortions in their eye or astigmatism in their eye. We'll go back to a two-dimensional image and right-click, select the pointer. Under the Attributes window, we can look at disease detection indices. Before we do so, let's just look at the main part of the window. The corneal astigmatism for this patient is measured as 10.5 diopters. This is an exceptionally high corneal astigmatism. We see a very flat K and a steep K. Having the flat K axis against the rule, axis 102, may be a good indication with the high corneal astigmatism and the asymmetrical appearance of the image that this is a pellucid marginal degeneration patient. We can look at the eccentricity values. When dealing with diseased eyes, they tend to have higher eccentricity values. Normal eccentricity is 0.65. This patient is very close to norm in terms of eccentricity, but certainly abnormal in terms of corneal astigmatism and against the rule, along with the appearance of the map showing the kissing doves or butterfly wings, as pellucid is often described in corneal topography, would indicate this is a diseased eye. We could also look at the scale range, and we go from 33 diopters on the flattest we can read to 48 diopters, the steepest the topographer can read, a scale range of 15 diopters. Normal corneas fall within 10 diopters, so this is an abnormal eye. We could look at the IS value, and corneas with inferior corneas steeper than 1.5, or in other words, if the IS value is greater than 1.5, that's indicative of a diseased or asymmetrical eye. In this case, the topographer is telling you the inferior cornea is steeper on average than the superior cornea by approximately 5.98 diopters. We could look at the surface asymmetry index and look at these oblique meridians. Is this hemichord similar to this hemichord? If not, the surface asymmetry index will be higher than normal. The same thing along this axis. So the more asymmetrical one side is as compared to the other and the opposing oblique meridian, if the surface asymmetry index is greater than 1.0, that would be indicative of a diseased or asymmetrical eye. Last value, surface regularity index, looks at the power distribution within the pupil. The greater the distribution of power, the more asymmetrical the eye, the greater the likelihood of disease. The threshold for abnormal would be greater than 0.8. If we were wanting to design a contact lens for this patient, we might go to the Home and Contact Lens. Then select from our available lens designs the appropriate trial lens that we would like to diagnostically fit. We then enter the spectacle RX if it weren't already entered on the patient window and say OK. And this brings up the contact lens design window. The first thing you might do is pick up the contact lens and put it on the geometric center of the topography if the maps weren't geometrically captured. Next, we might choose the appropriate lens diameter, in this case a 10.2. Next step is click your cursor in the center of the topography and determine the tear film thickness. With the present base curve, we have a tear film thickness of 37 microns. We desire somewhere between 30 and 40 for a diseased or asymmetrical eye. In a normal eye, we want around 20 to 25. Since we have 37, we'll consider this a healthy amount of apical clearance. Next, we'll drag this white axis line to the meridian with the greatest bearing. So observing the graph down below, which axis does the lens appear to land at on two opposing sides? In this case, at 12 o'clock, dotted section of the line here, corresponding dotted here. And at 6 o'clock, solid section of the line corresponding here. So 0 would be the corneal surface. We can see our contact lens lands at this point, then up to apical clearance, lands at this point. Then, which axis has our highest lift? Along the horizontal meridian or steep meridian, we appear to have a significant amount of pooling at 9 o'clock and 3 o'clock. This lens would be horribly unstable across that horizontal meridian with such significant clearance at 3 and 9 o'clock. With our bearing at 12 and 6 o'clock, the lens will not want to have a superior positioned lid attached type alignment with good movement with the blink, good tear pump. You would have movement along the horizontal meridian, possibly a positioning of the lens significantly nasal or temporal. So you can determine which contact lens parameter would be ideal for this eye. In this case, a scleral lens may be best suited for this patient with such asymmetry and such a steep horizontal meridian. A piggyback might be another option as well. This concludes video 10 on the review of functions and usage with your Medmont E300 Corneal Topographer.